Hello, it's Dr. Joseph, and thanks for joining us. Tonight I'll try and make this like, I don't know, 30, 45 minutes, something like that, and kind of get to the point. It's a bit of a smaller group, and so please chime in with questions. And if there's anything, or if anyone has had an injury that we're talking about and had a specific example of it, then please submit a question or make a comment about it. I kind of want this to try and be a little bit interactive with this. So my goal here is to kind of go over basically the stuff that keeps coming to my clinic all summer, every summer. And I guess I'm on my 15th or 16th summer. And so I'm starting to for sure see some patterns of the way that people get hurt in the mountains here, in kind of ways that you can recognize it yourself, and even ways that you can figure it out yourself with a couple of physical exam tricks that you can do on your friends or yourself to see if, oh boy, that is a little concerning, and that may be what worth them looking at, as opposed to, oh, okay, I'll just do some Advil and brace it a little bit or keep it quiet, and maybe it's something that'll go away on its own. So kind of some hints on what we use to determine, is this a bad injury, or is this something that is structurally failed and is actually going to need attention? Because a lot of patients are like, well, I wasn't sure if I should come in for this or not. And so that's part of this informational video. So I'll get started here. I'm going to advance this. Okay.
So if you click the slide,
Oh,
there.
so the mouse is here now.
There we go.
So what I'm going to go over today, of course, are bike crashes, which are super common, some golf and tennis injuries, pickleball, which has been, of course, a new one. I'm so impressed at how many people are getting involved in that. You know, there's a lot of new sports that come and go, and this one seems like it's here to stay. There's a really active crowd that enjoys pickleball, and we get a fair number of patterns of pickleball injuries, to be honest with you. The typical field sports, you know, soccer, etc., and then have a lot of hikers that have issues. And so I'll go into the common diagnosis with hiking pain, especially the knees. Motorcycle, I don't know, I'll touch on that a little bit, but those guys and girls always accept pain, and that's part of the deal of flying through the air on a motorcycle. And then a little bit of stand-up paddle, rock climbing, and then the kind of random ones that are fun, and they're fairly common, like the dog park injuries, camping injuries, various things like that, and some incidental stories of patients that I couldn't believe this happened to, which is always kind of fun to hear. So bike crashes. Trees are hard. Everybody knows that living here. Rocks are hard. Everybody knows that. There's a bunch of common things that people break coming off a bike. Anybody that's had a bike crash knows that it's pretty unforgiving. You know, we can all get away with crashing on the snow and anything where you slide it out, but even the simplest bike crash is a bit of a mess. We got a lot of wrist fractures. We get a lot of knee lacerations and finger fractures. Clavicle fractures are very common from that. There's a whole multitude of people going off the bike and getting hurt. A lot of rib fractures, we see them, but of course we don't have to do anything about that, just time. And so I'll kind of go over the more common ones that we have to address. So the clavicle fracture, like this one right here in the corner, that's kind of a typical one. When you look at it, it looks like this bone right here popped up. But in reality, this is attached to the sternum right there, and this bone is in the correct position. So once you understand that, then it's like, well, what the heck? This whole thing, my entire shoulder has dropped down. This entire thing belongs way up here. And so that helps people understand, okay, well, shoot, it's not going to work very good if we leave it down there. And so the rules say 1.5 centimeters. If it's displaced more than 1.5 centimeters, then you should consider fixing it. Most patients, if you've had these, are, of course, in a lot of pain. The spike of bone really hurts. And of all the surgeries that do, this is probably top 3 as far as rewarding. And what I mean by rewarding is patients are in a lot of pain, they have a lot of disability, they're hurting bad, and then you fix them. And I mean, in recovery room, they're like, oh, this is so much better. I'm attached. It's sore. Yeah, I just did surgery and broke my clavicle, but it's 10 times better than it was even in pre-op. And then the healing rate is almost 100%. So the healing rate does great on these. And so for lots of reasons, patients just do really well with them. And it's a total game changer on sleeping, and they heal in 6 weeks and they're back to their activity, and there's usually not other shoulder issues. So this is a real slam dunk for the patient and for us. This is how we typically fix them, with a purpose-built curved plate, countersunk screws, titanium, kind of low profile, and it holds it real still, and you can get it right back together, and it's a good surgery. So clavicle fractures. Wrist injuries is always sort of the debate of, well, I wasn't sure if I broke my wrist, you know, if I fractured it or broke it, or if I just sprained it. And I wasn't even sure if I needed to come here and have it checked out. And so I kind of wanted to go through a little bit of the common differences between a fractured bone in the wrist and a sprain, a ligament sprain, which of course is super common. So typically fractures bleed a lot more. They bleed a lot more than a small ligament. And so there's a lot more swelling, and sometimes it's even black and blue. So that's your first clue that it could be a broken bone, which is of course treated very differently than a ligament sprain. And so that's one clue. The other clue is to actually go to your own wrist and then kind of walk down the bone, right? The distal radius, the hard bone, and then you'll feel it gets kind of soft, and there's like a divot after the hard part. And then that's where all these ligaments live, is in that soft articulation of the wrist itself. So if you press on the bone here at the very end of the bone, and I happen to have a fancy little model here, of course, if I can find the camera. So here's our bone, right? And if you push on your own bone in this area and it really hurts on the bone, well then duh, it's probably a fracture, as opposed to if you're pushing on the ligaments there, then it's more commonly a sprain. Of course, fractures typically hurt worse, and when patients move it, there's a lot more increased pain. So those are sort of the clues we use. Is this a ligament injury, especially a low-level ligament injury, or is this a fracture? And as long as you protect it for a week or so, then it'll usually tell you if it's an in-betweener, where it could be either one, like a real low-level fracture or a small fracture that's acting like a sprain. If it's not getting better in a week or two, then usually it ends up being the bone. So that's another thing. Treatment for that, of course, RICE, which is rest, ice, compression, and elevation. And so with some protection, there's the compression part. So you have a wrist brace on there. Also, quite commonly is when it breaks, and it always breaks, or mostly breaks right here at the end of this bone at the distal radius. That's by far the most common place that it fails. And there's a lot of different ways that it breaks, but if it breaks and it displaces, it goes out of position, then of course we have to fix it, and usually that's done with a plate and screws. This is another fairly rewarding surgery, meaning that these approach 100% healing rate, and they do really well. So even a really bad fracture like this poor person, where the whole wrist and hand is all the way off the forearm, you can see the soft tissue shadow. It looks like they call it a dinner fork deformity. And so those are real obvious, and they go to the emergency room, push them back in place, and then we fix it like this. 6 to 8 weeks, they heal great. So it's rewarding in the fact that patients usually get full function back. There's not a cast involved. It's just a removable brace once it's fixed, because it's held by this big, strong plate. So that one is super common. That's another example of it. And you can tell that it's strong plate, no cast, full recovery, predictable. This one's tricky. So this one's important to recognize. You can see here's our distal radius, which is again the common one that breaks. And if you go a little past it, there's this long curved bone. And the shape of this bone is like a boat. And apparently scaphoid is the I think it's Greek or maybe it's Latin for the shape of a boat, because this is shaped like a boat. And the reason this bone is so important is there's two rows of bones here. So you got 4 bones and 4 bones. It's the link. So it links the distal row and the proximal row of our wrist, and that's why it always fails. That's why it breaks. So this proximal row stays put from the strong ligaments, and then it breaks through here. And the reason I say this is a tricky one is because this can act like a sprain. And when this acts like a sprain, it doesn't get held still enough because people put it in a simple removable brace and they move it. And then it acts like a sprain for 4 weeks, 6 weeks, 8 weeks, and then they come see us and we take an x-ray and they have an unhealed fracture right here. That can be a real mess. That can be a lifetime of wrist problems when these things don't heal because the blood supply is terrible and it can die. And if it dies, then all of a sudden you have literally a bad wrist in a 20-year-old or whatever age for the rest of your life. So it's important to understand the scaphoid fracture and the importance of this, of recognize it. In the emergency room, sometimes miss it, and sometimes family practice misses it. It's a common miss, and that's why I wanted to include it in this because it's an important one not to miss. So what I wanted to show you is how to find this. So let me see here, and I can show you. If you lift up your thumb like this, okay, so you lift your thumb up and then you feel down into this soft spot. So I'm on the thumb side, but I'm over here. And you can feel down in here, there's this divot. So you got a tendon, and a divot. And they call it the anatomic snuff box. And the reason is because apparently old ladies and men used to put snuff in it and do snuff back in like the 1800s or whatever. So, which is funny that that's hung out to be the anatomic snuff box, but it is kind of a little box that would, but anyway, inside of there, if you push inside of there, you're pushing right on that bone. And so if patients do that to themselves or to whoever they're concerned about, they push in that little triangle and it's like, oh, that really hurts me. Then no question about it, x-ray. You need an x-ray to see if it's a little hairline fracture of that or even worse, a regular fracture. So that's an important thing to note because when it is broken, it has to be really formally treated. We almost always recommend putting a screw across it because that can be a game changer as far as 100% healing if we put a screw across it. When they show up 2 months later, they've already lost blood supply to this piece, and then the horse is out of the barn. And it could be 2 or 3 surgeries with taking bone out of their hip and putting it in their scaphoid, and it's a big mess. So that's the take home on that is the snuff box, which is, again, that soft spot lifting your thumb up. That's a good one to know for everybody. So, yep, we'll switch a little bit to a different sport, golfing. That's about to turn on here. The most common with golfing is a tendonitis, is an elbow tendonitis. And then specifically, it's called an epicondylitis. And the reason is because the very end of this bone here, the humerus, has 2 bumps on it. And the bumps are called epicondyles. And they're at the very end of the end of the bone here. So we've got our humerus, our funny bone, our humerus. And then on the inside is the medial, the inside one on the inside of your elbow. Here's a bump. There's one on the outside. And the reason the little bumps are there, the anatomic sort of protuberances, is for an attachment of a tendon. And with golf and with tennis, they can both stir up and create these little tiny tears in the origin, meaning where it attaches, of course, on the origin of that tendon. And so the repetitive overuse will create pain there, and it can cause discomfort. There's not a specific that the medial one, meaning the inside, of course, elbow, is termed golfer's elbow, and the outside is the same process, termed tennis elbow, but they're pretty similar entities. And some golfers get a tennis elbow, and some tennis players get a golf elbow. I've had it on my own elbows, and I got it from rafting, from oaring, which is a grip, and you can't quit, of course. And so I felt it coming on, and I couldn't quit, and then the rest is history. They're very responsive to injections, and an injection heals it in like 90% of the cases. The book says the first 6 weeks you should do stretching with or without physical therapy, and rest, ice, compression, kind of the typical thing. They make little braces sometimes that people say works, but it's kind of hit or miss. And if patients go 6, 8, 10 weeks and they're like, nothing is working. And this is wearing me out because every time I grab anything from milk to a glass of water to whatever, I want to drop it. I can't cook. I can't hold a pot, a pedal, anything. And so they end up having an injection, and the injection is rewarding, 90% success rate. Once you get to 3 injections in a year, which is a long time, if it keeps coming back, then sometimes we'll do an operation to go fix this. Tennis elbow is exactly analogous on the outside. It's much more common. And sometimes patients say, well, I don't even do anything like that. I don't play tennis. I don't grip anything repetitively. I'm not riding bikes very much. I'm just not doing that static grip. How did I get this? And part of the reason is that this area right here on this guy's elbow, who must work out more than I do, has poor blood supply in this area. And it's kind of what we call a watershed area, meaning it does not have a dedicated blood supply. So little trickly arteries and arterioles barely make it there. So you get any little repetitive thing to that, and it has trouble healing itself. And then it gets inflamed, and then it hurts, and that's why it's so common. So that's where we are with that. The surgery does work, but it's about 6-week recovery, and I don't go there unless patients are like, all right, we've tried everything, we need to do something else. This is the location, again, of that surgery there. This is basically what it actually looks like. It's pretty white and fibrous. That's where the incision is, and you go down on top of that epicondyle, or that bump, and then you'll go through a clean sort of layer, and then when you get deeper down in there, it gets kind of grayish and like this, like they use all these tricky words, angiofibrotic and dysplastic, but it's because we don't really understand it, so we add really weird words like that to it, and it kind of is like kind of just junky tissue is the way I think of it. And it's lost blood supply, and it's grayish, and it doesn't look shiny and white and healthy. And so you literally remove it and you excise it, you lips it out, and then you sew the good stuff side to side. You put an anchor or two literally in the bone there, and then you sew that whole package back down in the bone. And it does work, but as you can imagine, they're a little bit sore, and then it takes 6 weeks for that to literally grow in, but it does work. And again, only 10% lead to surgery, so the injections are quite rewarding with that. Overuse, yep. So another flavor of sort of overuse with golf and tennis is rotator cuff tendonitis, bursitis. And those words are sort of thrown around. So I wanted to explain a little bit more about what is tendonitis, what is rotator cuff tendonitis, what is rotator cuff bursitis, what is rotator cuff impingement, or what is shoulder impingement. And they're all pretty much the same idea. So the way to think about it is that they're all fairly similar, and they're super common. So I'm 51, and it's remarkable how many of my friends around here like, hey man, like I'm having a problem with my shoulder. It just came out of nowhere. It's bugging me when I sleep, and I don't think I hurt myself. But what do you think it is? And of course, being, in the 50s and somewhat active and doing stuff outside, etc., we're kind of a setup for that. And then a lot of people that want to start working out more, because again, 50, 60, 70, all right, I want to stay fit. I want to keep moving. So you start doing some weightlifting, and especially overhead stuff. That's the setup. We see it swimmers, volleyball players. That's who gets this. And so you want to sort of be aware of that if you're doing a lot of overhead activities, that if you start having pain, then this is common. So to explain it a little better, this is sort of a decent picture of the shoulder. So here's our humerus, right at the top of the humerus, the ball of the humerus. And then here's what's called the acromion. So on this model, let's see if I can get it in front of the camera. Same idea. So we've got the ball right here, and then we've got this shelf of bone, let's call it the acromion. And then right where my finger is inside here, kind of stuffed. It's hard to do this without looking. Anyway, inside of there is where the rotator cuff lives, right? So it's living in there, and it's pulling your shoulder up. On top of this, in between the actual rope, which is a tendon, and the bone, is a bursa. And so the bursa is like a pouch. And on this picture is this sort of pink business right here is kind of the bursa. And then the white stuff, of course, are the tendons. And the idea is that if you raise up a lot repetitively, it can pinch. And it pinches this bursa, and that's the impingement. And it gets red, inflamed, irritated. the tendon itself gets kind of mad and inflamed, and then there you go. You've got bursitis, you've got impingement, you've got tendonitis. The way to test it to see, all right, well, could I have a torn tissue, or is this just pinched tissue like you're talking about, which is more common than torn tissue, is if patients have a distinct injury, they come off a bike, let's call it, and wham, and then all of a sudden they're like, I can't lift my arm. Well, that's a torn tendon. That's not going to be bursitis. Bursitis is I painted two rooms in my house and I was overhead a lot. Now my shoulder hurts. That's bursitis. That just sort of sneaks in. It's usually worse at night, interestingly, because your shoulder, the weight of your arm, right, all day long opens up this space. And then at night, the weight of your arm goes away because you're laying down, and it just gently rises up and it just pinches right there. So it's common when patients say, yeah, it's honestly worse at night. That's always a nice clue that this is more of an impingement or bursitis with a good story. And the reason I'm detailing that is because if you get annoyed with this and nothing's working, the regular stuff like ice, anti-inflammatories, PT, and activity modification, changing what you're doing that's making it mad, then it's the same thing. A little splash of cortisone doesn't even hurt that bad back there, can be an overnight success. Sometimes it's a full silver bullet injection where patients that evening are like, oh my God, I've been dealing with this for months. It is literally gone. So we're real quick to offer that if we think that it's impingement or bursitis. There's an injury and there's a lot of weakness, then we're back to, oh, did you tear your rotator cuff? But again, this is super, super common. So the next thing I think I'm going to do is, yeah, so here's, PT, ibuprofen is Advil, of course, and naproxen is Aleve, and it's kind of take it or leave it. That tends to be what most people like versus Tylenol. Some people have to take Tylenol because of their stomach. But naproxen and ibuprofen, of course, is the exact same thing, and the generic is exactly as equally effective as the prescription. And then changing the activity, that part can be important because if patients are like, well, I love swimming, it's so good for me, and it is, but it bugs my shoulder, where you have to just pause or do a breaststroke, let's say, instead of the crawl where you're more overhead, because you're going to keep poking the bee's nest. So then, and this is sort of the test for it. I mentioned one thing is you push straight up like that and you try and resist that. And if that hurts you to lift your arm straight in front of you, that's the impingement test or the near sign. This other young lady here, this is the other test where you roll the arm in. So he's pushing down right there and then trying to push her down and roll her down. And that tries to roll the bumps on the humerus up, which impinges and pinches. So if you do like this one here and you roll it down and patients are like, oh yeah, that's worse. That's usually impingement. So those are good tricks to know if somebody's, thinking that that's what they may have. So this is separate. This is if they've got a worse story, let's call it, where they jerked on something and are trying to sling a bag of wet whatever up and over a fence or into a dumpster is a real common one. And then they feel, something, I felt it pop, I felt pain. And right after that, I couldn't lift my arm very good. Well, that's the bad story. That's the rotator cuff tear story. Or you come off your bike or you crash skiing or whatever it is. It's usually an injury. It doesn't always have to be. There can be a chronic tear also, but sometimes or usually there's an inciting event. This test right here is called the empty can test. And basically not with your arm straight in front of you, but you bring it out a little bit. So instead of being straight like I am here, you want to go out about 45 degrees, not 90 degrees all the way and not straight on, but halfway there at 45. And then you thumbs down, you put your thumbs down to empty the can, and then you push up like this lady's doing. And that specifically tests the most common tendon that's torn in the rotator cuff, which is called the supraspinatus. And I think it makes up like 85% of the tears it's involved. So that's how you test that. And if patients have a lot of pain and weakness from that, then it's more suspicious that it could be torn tissue and not just impingement. So that's a good one to sort of know. And then one sort of piece of advice that most people learn either the hard way or just because they're smart is that as we get older, we're less and less elastic. And so the 20-year-old can jerk on that cord to start the whatever 500 times and they can get away with that. But the older we get, the less our body, specifically our tendon attachments, like jerking. So you can apply a real heavy load and that's fine, but be careful with sort of jerking in life, because that's how we always see the biceps tendon fail, either at the shoulder or at the elbow, or commonly jerking to get the something to move. I've had one myself where I tried to pull a plant, a little bitty tree out of the ground, and immediately felt it tear. And I was like, that is so stupid. I know better than that. So that's it. We also get the tear sometimes from golfers hitting the green ball instead of the white one. So let's see, rotator cuff tears. Yeah, that's probably the bulk of that. So switching gears a little bit, we mentioned pickleball. I've heard it's great. I keep saying I'm going to play it just to understand it a little better, because I have a number of patients that tell me how fun it is also, and also tell me that they've got hurt doing it or that it made something mad. And it's typically tends to be the knees. It can be other stuff too if it's a trip and fall, but it's quite commonly knees that get bugged by it. There's, of course, a lot of pivoting and shifting and twisting, not unlike tennis, but people even say it's more like badminton. And so it's a little bit of a setup to sort of tick off an arthritic knee, let's call it. And it's also a setup to tear a little bit of the meniscus. So I kind of wanted to go into, well, what is a meniscal tear and how do people get it, and how do you know you have it? It's usually, but not always, usually some degree, and I'll kind of do the model thing again, some degree of rotary torque. So you're planted, and then here's the meniscus that are of course inside of there, these two rubbery guys, and then you load it, and you're loaded, and then you twist, and it twists. And what tends to tear is a little more of this thin portion. So the way this thing's shaped, the outside of it is thick. It's the important cushion. The inside is thin, and the inside is what tends to tear, obviously for biomechanical reasons. And so the way you can tell is you typically, patients will have pain right on the sides of their knees. So you can come down your own femur and walk down the femur, and then it gets a little soft before you start on your tibia. That's where the meniscus lives. And so if you have pain, and it can be very specific, so you kind of walk your bone, and then soft spot, okay, that's your meniscus. If you have pain right there, then it becomes suspicious. And then there's usually a bit of swelling in the whole knee. Most people see the swelling in the knee, in the top of the knee. So then they're always like, well, how does that hurt if I'm swollen up here? It's, of course, because it's one big joint, one big package of fluid, and the easiest place to see it is actually at the top of the knee there. And then small tears can either heal, especially if they're on the outside, or they can be minimally symptomatic, and we don't do anything about it. We just sort of watch them. But if they bug patients enough where it keeps going and going, then of course those are the ones that we fix. Squatting is really common. So if people squat down for a pickleball shot, or squat down to work on something down, and they squat down like that, what happens is it rolls, it cams back. Okay, it's a cam mechanism, meaning it, let me get it set up here. It rolls back like that. And what that does is it puts a lot of pressure on the back of the meniscus, which is the posterior horn. So back in there. And then it pinches it. So if you're in a squatted position and then you load it with a pinch, that's what can tear the thing. And so to squat, you just want to be a little more aware of that, that's there. So then you hear about, okay, well, my friend's got a meniscus tear. Are they going to repair it? Or are they going to trim it out? And basically only about 10% of all comers of all ages can be actually repaired. And what I mean by repaired is sewn together. So 90% of meniscal tears are in the thin portion, like this is showing, and like this is showing. And basically this doesn't have any blood supply. So you can put a stitch in this all day long and it's not going to heal. And I just noticed on this design that they drew it red like this. And the reason they did that probably is because this is called the red zone and it has blood supply. And the further you, of course, get in here, it becomes more white zone, and that's less blood supply. And so it can't ever heal. So it's very easy. We just go and trim it out, and patients do great from that. I've had the surgery on my own body, and it's very rewarding because it tends to work. And you can walk on it day one, and it's not very painful. You don't need narcotics, and it's a good surgery that works. So alternatively, if you're torn towards the outside, then the right answer is to put stitches in it. You put stitches in it, you're looking at 6 weeks to ask this thing to heal. just like any other stitch, anything else you sew together, you have to ask it to heal. And so you have to protect it, be more cautious, sometimes crutches, limitations on squatting, various things like that. Again, 90% of these tears are in the thin business, and we can trim them out. And that's the meniscus tear that's like, oh yeah, that was an easy surgery. I had a lady this winter back skiing at 6 days out. I was like, that is a little early, but she did it. So
quick question about meniscus tears. And so this is from Rose. She wants to know if you have 80% or 80% of your meniscus removed due to an injury and you end up with spontaneous necrosis, can the necrosis ever heal? If you delay surgery, does that make your knee worse?
Yeah, so that's a pretty involved question, meaning that what she's getting at, I think, is that if you have a good bit of your meniscus removed, and back in the day, we used to remove more of it than we do now. So we used to, in fact, we used to remove the whole thing back in the 60s and 70s through an open procedure. We thought it was expendable. And what we found is that causes arthritis. And so in her situation, it sounds like that a lot of meniscus was removed probably a while ago, and it increased the pressure on the bone, and then the bone is now reacting. So when the bone reacts, it can get edema, it can sometimes lose blood supply, and you can have problems deep down in, not even in the joint, but actually further into the bone itself. And those increased contact pressures is what she's asking about. So the whole role of this meniscus right here is to decrease the contact pressures like a rubbery spacer. And so if they increase, then it can create issues with the bone. And, you know, honestly, if it's more and more symptomatic in your case where it keeps on being more painful with increased use, then it may be that the osteonecrosis is expanding. And so we would often recommend getting an MRI and then a different MRI like 6 months or a year later and just literally measure and see if it's changing. But a lot of osteonecrosis in the femur and the tibia, because they have good blood supply, it can heal up naturally on its own, meaning the bone can sort itself out. So that's a little bit of a tricky question, but that's probably what's going on there. It is very common for meniscuses to tear with arthritis. So you can have the classic injury where you twist it and you have the big acute tear, which is what this one kind of looks like. And then you go in and trim it out. They don't have any arthritis at all, good smooth surfaces. But almost more commonly is sort of the mildly arthritic knee in the 50, 60, 70-year-old that twists it playing pickleball, let's say, and then all of a sudden they're like, oh, I found something in there, and ever since then it's bugged me. So it was kind of slowly tearing and getting banged up over life, and then all of a sudden one bad move split the tear. That's definitely fairly common with that. It's easy to treat because, again, you smooth it out. And this slide here is basically some of the tools that we use. This is the most common right here, has an inner sleeve and an outer sleeve, and then the inner sleeve oscillates. So it doesn't spin in there, it would wrap up a bunch of stuff. It oscillates back and forth. And the little teeth, you put the little teeth, of course, on the torn tissue, and then you turn on the juice, meaning the fluid, because this is all underwater, and then it pulls it into the little instrument, and then it just gently shaves it. So back and forth, it just shaves it, and you just buff along there, and really fairly easily takes it from this to this and smooths it out nicely. And then again, patients walk on it straight away. You can also use these little biters, kind of like that old game Hungry Hippos, where you send them in there and kind of bite the edge of the meniscus to smooth it out. And so these work really good. You take it back to a stable rim, and patients tend to do well. The hard part is sometimes these are in conjunction, as I said, with arthritis, and you can't really fix the arthritis that's there. So kind of mention that short surgery, usually no crutches. The idea, just so you fully understand it, is you inflate the knee with some water. Okay, so there's water that's coming in right here with the camera. This is the light for the camera, and this is the camera and the focus knob. And then you of course, go in the knee with the camera, and then you fill it up with fluid. This right here is the outflow, meaning where the water takes off and leaves. And then you use the other little portal, which are real small, to put in the shaver or the probe or whatever little tool you're using. And so you just go look all around and clean it all up. And again, they do really well. So it's a nice rewarding surgery for the patient and for the doc, especially when they don't have arthritis. So any other questions about meniscus?
moment. We had one about ACLs. We can kind of save that towards the end.
Okay, well, and that's what I'll do with this because we're going to do, I think, ACLs right now. And so switching to a little bit more dynamic sporting injuries, we don't get that many ACLs from pickleball because it's a little more controlled and less ballistic, let's call it. But then you get a full speed twist or that awkward ski twist, and then you're starting to talk ACLs with that. And so that's more common. This is what I was trying to describe about that swelling above the patella, the suprapatellar, the swelling there. So you lose these here. ACLs swell a lot more than meniscuses. So here's a normal ACL, and then here's a torn one. And so that's the way it plugs into the tibia here, and it plugs into the femur way back up inside of there. The classic pop that I'm sure everyone's heard about. It really is a real thing. It kind of has sort of a pow like that. You can tuck your finger under your and make a noise, and it's like, yes, that's exactly what it sounds like. And that's never a good thing. And there's usually immediate swelling, and then there's distrust and instability that can be right away, that can be the next morning type thing. Those are common words that are used with ACL. So most people around here, being as active as everyone is, they want to fix it. And the goal of fixing it is to return to sport. And that's the idea. Most sports that involve pivot, shifting, twisting, be it tennis, basketball, soccer, skiing, etc., you need an ACL to have a stable knee. There's exceptions to that where it can scar in, and people can get lucky if it scars in enough. And that's what you hear of your friend that said, oh, I never had mine fixed. And sometimes they're partial injuries, which you don't have to fix. So some people had a partial injury a long time ago they didn't fix, and those do fine without surgery. So, but you can't just sew that thing. I mean, you can tell from this picture here, you can't sew that back. It looks like a busted mop end, and it looks exactly the same on the other side, on the femoral side. There's no sewing that back together. And that's why you've heard people call this an ACL reconstruction. So it's not a repair. You're not repairing it like we sew it together. You put in a new one. And the way you put in a new one is you make a tunnel in the tibia, you make a tunnel in the femur, you try and make the tunnels right where the old ones were for obvious reasons, because you're trying to reconstruct the anatomy as it was before. And then you make these tunnels, you put in the graft, which can be your own tissue or it can be cadaver tissue. And I think I mentioned a little of that in a minute. And then we attach it at either end. There's a whole bunch of ways to attach it, and all of them work fine. And then literally it has to grow into the tunnel. That's the reason this is 6 months recovery. But you can walk on it straight away, and it's a little bigger surgery because they drill on the bone. And that's why these are a little harder to get over, and people are on crutches, etc. Usually crutches is 1 or 2 weeks. In 3 months, we let you bike or do straight line stuff, but 6 months for pivoting, shifting sports. There's a lot of PT involved. The graft choice is either do you use your own tissue? A lot of people choose to do that. It's usually age dependent. Some of the studies, they all work, but there's been some studies implying if you're younger than 35, you should consider using your own tissue. To try and increase the 96% to 97% success, but they're all pretty good numbers when you look at big numbers like 10,000 of them, which is pretty easy to study because they're common. And so then your choice is, do you use your hamstrings, do you use your patellar tendon, or do you use quad tendon? And there's a bunch of choices. A lot of people go to hamstrings, but they all three work. And so it's not terribly important. There are pros and cons to each one. This is kind of what it looks like. So here's a hamstring tendon that's doubled over on itself. And so doubling it over makes it thicker like the original patellar tendon. And this is sort of borrowing the hamstrings there. And remarkably, there's not that much hamstring weakness, which I was always surprised of. But even like the Lindsey Vonns of the world had her hamstring used, and you're talking hundredths of a second. So that was sort of convincing that, it must not affect you that much if you can get over that to lend those out. And then this is a patellar tendon with a piece of bone on each end, and same idea. You put them in, and they all again work fine. So let's talk about a little more about arthritis and about hiking. Super common, or we can do that ACL question.
Yes, that would actually be a great time. This would actually be a great time for us. This question is from Claire. She said, I had ACL replacement and then a year and a half later, meniscus repair on the same knee. I'm 7 months out from that surgery, but I'm still finding it's hard to know when to stop an activity when I experience pain. Are there specific spots in or around my knee that are worse areas to experience pain in? And then at what level, 1 through 10, should I stop activity?
Yeah, so what she's kind of asking is, what is my pain generator? Like, what is creating the pain that she's experiencing when she gets to a certain level of activity? It would be a way to phrase that, because it sounds like with a lot of things it's not hurting you, and then all of a sudden you get to this certain level and it's like, oh, now it's starting to hurt. Should I respect that pain or not? I don't think, it doesn't sound like it's coming from the ACL. That would be unusual if the ACL that far out was creating pain. So that's kind of probably out of the picture. And then you go back to the meniscus, and if it was actually a repair, is that what she said, a repair? So I'm inferring that means, I think that's the right verb, that means that was sewn together and repaired together, like I was showing. And if that's the case, then some of these will only partially heal. And if it partially heals, then that's frustrating. It'll keep on going and it'll keep on talking to you. So if you have, let's call it joint line pain, which we talked about a minute ago, at the same meniscus on the same side that you had the repair on, then we get more and more suspicious that it didn't heal completely. Because when you look at all comers of meniscal repairs, there's a high number that actually doesn't heal. It's like 24%, I think, is the number of all comers. So you got 50-year-olds, you got 20-year-olds, you got terrible tears, you got wimpy tears. All comers, 24% don't heal. That's a big number, 1 out of 4. And so we get more and more suspicious if patients keep having pain at the meniscus, and if you have swelling. If you notice at the end of the day, after it hurts, when you did quote too much with, let's call it 5 out of 10 pain or 3 out of 10 or more pain on the scale, then if you have pain there and swelling, the swelling's a red flag. That's saying, I'm trying to still fix something. I'm calling on the troops to try and fix this meniscus. And so that would be, those would be the red flags to get a new MRI and look at it, would be the way I'd go about that. The other alternative would be if it's just chronically inflamed, meaning if your knee just still hadn't become happy with it and it's staying inflamed 6 months out, 7 months out, then you could also consider cheating and putting in a little cortisone shot in your knee and see what happens. And if that makes the pain go away, then it was inflammatory and it was getting pinched. If that does not make the pain go away, then we're taking 3 steps back saying that this sounds more structural, consider the MRI. So back to hiking and arthritis. So that's a common combination for lots of reasons. And everyone that hikes and has some knee pain, that's the first thing we think of, is a little bit of arthritis, unless it's with a twisted injury where I tripped and fell hiking. But if they have pain, and it's typically going downhill. So almost everyone says, no, I can get up pretty good. It's more controlled. It's when I'm coming down. And the reason for that is bang, 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 bang. That pounding on the cartilage is what it doesn't like in there. So walking poles can for sure help with that pounding. And some people will say that a simple sleeve or a brace, that's the simplest, with no real angles on it. No hinges on it. This is sort of a half step up with a little bit of a hinge, and this is a little bit of a more hinge. And some people say just a simple sleeve starts, it helps contain it and may sort of keep it together a little bit so it doesn't get quite the pounding. If it's more of an injury, then we start leaning more on that you need a hinge on there. So I kind of wanted to back up a step and say, well, you just throw that word around, arthritis. So what exactly is arthritis, and what does that mean to you, to us? Well, the way I think about it is, it's the thinning or the wearing down of good slippery cartilage on the end of the bone. So obviously a joint is made up of 2 surfaces that are sliding on each other. And that surface is called articular cartilage. It articulates, right? So that slippery cartilage is the good stuff. And that good stuff can basically be damaged. It can wear down with life. There's a little bit of a hereditary component to it, where it can just thin. And that's the idea of, my mom had knee replacements, my grandfather had hip replacements. And so there's a hereditary component. And honestly, there's part of arthritis that we don't understand what it is. Is it a certain factor that's floating in your in your articular fluid. There's lots of theories of why some people have it worse or not. But it is so common that it's interesting that we can't truly figure out, well, quote, what causes it. So, but the common ones are an injury or an overuse type situation or hereditary with that. And so I think of it as kind of the rubber on the tires is often the word I'll use to explain it when patients have a cartilage injury. And then when it gets thin, it creates more friction, and then that creates more inflammation. The inflammation is what people feel. That's what hurts you. That's what creates the pain. And that's why a cortisone shot can help an arthritic knee. And then the rubber wears all the way off the tires and the radials show through. And then it starts rubbing, literally, as everybody's heard, bone on bone. And then once the raw bone is rubbing on raw bone, then there's nothing you can do but replace it. You can't put in new cartilage there. It doesn't work that way. So this is sort of a normal joint space on the knee, and this is the kind of advanced changes where you lose a bunch of space because, again, we lost that articular cartilage that allows us to narrow down. And there's a bunch of other changes with bone spurs that come off the side and things like that. And so, of course, on a knee like this, putting a scope in there and cleaning it up is not going to do anything much. You're going to need a knee replacement. Shrink this down a lot less where it's just a little bit narrowed and then a little bit of a meniscus tear. That's the patient that may get years of benefit from smoothing it out. The only thing that we can do to arthritis with a knee scope, okay, not a knee replacement, is we can clean up the edges. So here's this pink bone. We don't like to see the pink bone here. The cartilage is the white stuff, and it starts to delaminate. It'll start to peel up like that. And so obviously that'll peel off more and more, and we don't want that process to continue. So with that same little shaver, you smooth it out, buff it out, and it slows down the progression. But there's not much we can do for the little bit of raw bone peeking out, but I'll show you what the only choices we have for that. So people always ask, well, there's a way to prevent it. Prevent it's tricky. You know, if there was a way to prevent it consistently, then we would put it in our water dispenser in the lobby of the clinic here. So it's difficult to prevent arthritis. It kind of is what it is. There's natural history to it. There's these medicines which are at the grocery store and the pharmacies are amino acids, glucosamine and chondroitin sulfate. And I mention these because they've been around more than 50 years. And anything that lasted that long, there's some merit to it. And I say sort of the same thing about acupuncture, is I don't really understand it. I'm not trained in it, but it's still, people sometimes swear by it. And it's been around thousands of years. So it's in the same category. These amino acids, they're amino acids that are building blocks for the cartilage. And so maybe there's some preservation or health of it, but it's not like if you take these, you're going to build new cartilage. It just doesn't work that way. You're not going to make new cartilage. And then there's also a lot of discussion about stem cells and a lot of discussion about PRP. There's never any harm to that, but it typically doesn't magically grow cartilage. Now, people get relief from it, and I'm not saying it doesn't help them, but the hard science on that, it can't grow articular cartilage. This stuff is not grown by adding PRP. And that's not to say it won't help you, because a lot of patients say, well, it's worth a try. It helped my friend, and I want to try it before giving it a knee replacement. And that's common that people do that. Insurances don't cover it, of course, because there's not enough science behind it. There's some soft science. This mostly from people that deal with it a lot. So again, there's a lot of discussion about that, and that field is kind of developing. But I can promise you, if it grew new cartilage, we would do it on everybody. And so that's kind of my quick 10,000 foot stem cell thing. Cartilage flap, slowing down the delamination. What we can do, and what is somewhat proven by the science, is if you do have a discrete area, so you got good healthy stuff here, you got good, relatively good white, slippery, healthy stuff, and then this big injury, let's call it, or a big divot, then you can go there and you poke little holes called microfracture, and these things on purpose are supposed to bleed a little, and then they bleed a little, and then it creates a fibrous covering. And it's, of course, not as good as the good stuff, but it's a fibrous covering on the raw bone, and that can help patients, and it can basically buy time or even make them asymptomatic or way less symptomatic. Cortisone injection, I mentioned that for the inflammatory pain. It's an easy thing to try for arthritis. Viscosupplementation, that's this rooster juice that people ask about and have heard about. The more common is Synvisc. The way I kind of think about this viscosupplementation is it's kind of like motor oil, where you're putting in something viscous and you're trying to supplement the normal shear forces, the normal friction between these surfaces that's increasing because they're wearing out. And so we try that, and if patients are like, yeehaw, then that's great, but it only carries about a 60 to 70% success. But when it does work, it can last for a long time. And I've got a number of patients that I inject them every 6 months with the Synvisc or any of the other ones. Are all pretty similar. And they say, no, this gets me through my whole summer. It gets me through my whole winter. And so in that 60 to 70% patient, that's worth considering and trying. And it's just a sort of fancier injection, but it typically has to be approved, not by Medicare, but by most insurances. So that's the thoughts on arthritis. I don't have any other like magical ideas on, well, how do you prevent arthritis? It's a real common topic, and there's a lot of different supplements out there. There's a lot of different things that are, you know, copper and magnets, and it goes on and on. And again, some people swear by some of these, and it's worth a try. But the hard science on it is kind of what I just presented with that. If it came to a knee replacement, that's a good surgery. It's a bigger surgery, but the numbers on it are excellent, and it carries like a 95% success rate. And so if it gets to that, you know, there's a bunch. I had a patroller literally yesterday that that has a knee replacement, and he's a hell of a skier, and he's been doing it forever, and he's still, of course, skiing with his knee replacement. It's really common. So if you have to get into it, it works. Switching gears a little bit to hand and thumb arthritis. That is really common. We see it commonly in the summer, getting aggravated with the racket sports, with the golf, of course, even the ski poles for hiking, and anything with gripping or just repetitive activity. A lot of patients don't have any sport they're doing, they just have pain from that. And so how do I get the mouse to go back up top again somehow?
Guess what?
The mouse is down here now instead of
Move it. I got it. There you go.
oh, great.
Oops, sorry.
So it's really common because the base of the thumb, the way this joint is shaped is not a hinge. Most of the joints, of course, on your finger and your hand are hinges for the most part, and it operates like a hinge. But if you look real carefully at the base of your thumb, like, you know, not the moving part, I gotta find the, not here, but you go down further to at the base of your hand where the thumb is, that joint right there is right here. And it moves all over the place, up, down, sideways on purpose. So it's inherently unstable, and it tends to wear itself out down here at the bottom of the thumb. Exceptionally common. It is really rewarding with the injection, even if it's quote bone on bone. Some patients will get years of relief, and I don't ever understand exactly why that is. I guess it's that we're not walking on our hands, or that it really works great. So we're very quick to do injections for that. If patients get less than 6 months of relief and then 3 months of relief, and we try it again, and then it's like, now it's not working, it's not lasting long enough, so there's 3 in a year, let's say, then we're pretty quick to say, well, consider fixing it. The fix is predictable. It also carries a really good number of successes for pain relief, and the function is usually really good. And this surgery, kind of bizarrely, you remove the arthritic bone. So here it is right here. This is that arthritic bone. And basically you just literally remove it and get rid of that bone. We take advantage of the fact that that old joint used to move all over the place like a ball. So it can go left, right, up, down, you know, and make circles. And so this, after 6 weeks, this turns into a mature ball of fiber, let's call it. And then it's this good spacer, a fibrous spacer. And so it works like a regular thumb, and patients get back their strength because it doesn't hurt anymore. And so it's a good surgery if it comes to the point where nothing is working. but it's a full 6-week commitment. There's never, I tell patients, there's never a time you have to do it. So it's like, it's the same surgery if I do it tomorrow, if I do it in 5 years. So you tell me when you want to do it. It's not like, oh, you should have done it last year. It's really completely up to the patient, because it's the same success rate if we do it sooner or later.
We have a question from Francis. He says, I am wondering about a hard knot in the palm of my right hand at the base of my 4th finger. It happened when I gripped the strap of my ski pole while going down the mountain.
So the most probable thing, I doubt that he tore anything gripping that, because if he tore something, then he would probably have problems moving. You would probably have problems moving your hand or moving your finger, and it would swell, and it would act like more of an injury, like you injured tissue. And that's kind of not, I don't think, what you're saying. I think you just sort of said that you noticed it, or felt like that you were saying that you just sort of noticed that thing there. So whether that's related to the gripping or not, it's probably a cyst that are real common on this side of the hand. The cysts on the wrists are back here most commonly, and the cysts on the fingers are on this side more commonly. And if it just literally showed up one day and it's kind of a knot, then it's either going to be a fibrous nodule, which is just kind of a firmer thing, or it's going to be a cyst that's there. And basically, in general, we can ignore them unless they hurt. And unless they're getting in the way, that's what we tend to do the operation for, to remove those. So, yeah, kind of mentioned the thumb surgery. It's a good one. So now we're going to do another like 5 or 10 minutes of sort of more of the weird stuff, and then open it up to any just generic questions about orthopedic stuff. So it's surprising how many injuries that I get from dog park stuff. And it may be because I do a lot of upper extremity, like wrists and hands, and also do a lot of knees. So that's sort of the setup here at the dog park. And everyone that's been to the dog park knows about the 3 dogs crashing into the group of 3 people that are catching up. And it happens a lot, and it happens commonly, more commonly than you'd think. And so they either come crashing in from the side and they tear your MCL, which is the ligament on the inside of your knee that heals really well. Or worse yet, they come in from literally behind you, like that NFL clipping injury where you have no idea it's coming. And then all of a sudden it really violently hits the back of your knee. And just the height of the dog seems to hit right there on the back. And there's a reason that it's against the rules in clipping, because it can cause bad ligament injuries. And I've seen a number of ACL tears from dog parks, which people are like, oh my God, it's such a lame story. But it happens. And so when I'm there, which I like to go to, I'll lock out my knees, as I see them come creaming around and heading towards you. You kind of lock out, and brace yourself a little bit without even stopping the conversation, because I see it so often. So that's just one to be aware of, that happens more than you would think. The other thing is we get a lot of broken bones from dog leashes. We get where you wrap it around your finger and it breaks off like this right here. That I see that probably at least once a month, maybe even more, from a dog leash that was wrapped around and then took off. We get like this guy with this, he looks sturdy enough to handle it, but you get rotator cuff injuries where the dog has a big slack and then a huge jerk like we talked about that are no good for tendons. So that's a common one that we'll get, as a big old jerk from the rotator cuff injuries, or even elbow ligament injuries or tendon injuries from a bigger dog with a jerk there. The dog collar, if you get your finger up underneath the collar, way up under there, and then the dog tries to get away from you and does a twist and you can't get it out of there. I've seen a bunch of little fractures from that. Some are bad, some are good from dog collar twists, but that's definitely a thing. Sometimes it can just tear the ligaments there, but they can be kind of annoying and take a long time to heal too. So that's dog leashes and dog collars. Now these are some really weird ones. So this guy, I saw him today in clinic, and so I had to put him in the talk, and I told him, and this of course isn't him, but he was in Avon, and it was a windy day. This is about a month ago. And it was that gusty, like really gusty, windy day that he made the paper, etc. And he stopped to check his oil, and he opened his hood, right? And maybe you can see it coming. He's checking his oil, and a proper gust of wind goes, and most of the hoods nowadays have just the springs, right? They don't have that old bar that opens up and really holds it wide open. They just kind of open with the springs. Well, it came down on him and smashed one of his hands in there, and it locked. The hood locked, and he's by himself. And he had an open fracture, so it busted him bad and tore open his tendon and broke his bone and came out of the skin. But he's stuck by himself, which isn't funny, under the hood of his car. And he starts yelling and screaming, and it's still daylight. He said it was like 4 o'clock, 5 o'clock, and he's yelling. I mean, this thing hurts, and he's stuck. He can't pull his hand out. And people are hearing him from the bike path, and he's yelling at top of his lungs. And they're like, I'm not going to go touch that guy. He's freaking out. And they wouldn't help him. And he told me it was 15 minutes before he got basically a lady into his, grandma, like 70, 75, to work her way up the hill and really get a look at his face like, oh my God, no, he's in pain. He's trapped. And so he talked her into going and pulling the release. And that was that. And so that was a first for me. So if you're going to do something under the hood, don't do it on a windy day or think about where you're parking. So anyway, that was, I had to put that one in. This one with camping, we get a lot of ding dongs camping with or without a bunch of beer that are holding a piece of wood, not like this guy. They're holding it, of course, vertically, the easy way. And then they put the hatchet. And they're trying to go slow, and they're probably thinking about it a little bit, but do we get this hatchet injury every summer from usually younger patients for obvious reasons, but that's a common one. And so hatchets are a little worse than what people think. Now the cigar cutter, this was another weird one that I had this young lady. She was like 18, and this is about a year ago, and they were smoking cigars with her uncle or something. And she made a joke about a circumcision, and she put her own finger in the thing and as a joke clipped it, and it cut through all her tendons in her finger, which is a big deal because they're really hard to repair. They don't do well, and it takes forever, and it changes your finger forever. So I don't think anyone on this webinar would be that person, but anyway, so yeah, she'll only do that once. So yeah, let's see what other ones. Yeah, this one is really common. This is not the way to put the knives in the washing machine, in the dishwasher, I mean. And so even 2 nights ago, I went to my house, and my friend helped me load the dishwasher, and I took it out yesterday, and there were 2 knives like this. That's just not the way to do it, because I get an injury from this every year of someone reaching in there, or even a younger person that's trying to help. So that's, of course, not the way to do it. Ring avulsion injuries they have their own classification because they're so bad. It's often can be on a ladder, let's call it, and you're climbing up a ladder and you're coming back down and you slip, and the ring actually catches on to something. And when it catches on, these are terrible injuries. You can imagine that this not only hurts, but it completely degloves it. And it's a known entity that are just terrible. So kind of think about a little bit more of your own ring if you're doing something where you're worried that it could get literally caught on something as you fall. And it seems like ladders seem to be the theme there, because you're obviously gripping real strong. So that's just food for thought. Another one that I get a number of times a year is the delicate wine glass in the sink. And so I don't even, and especially with that soapy layer. So you got the soapy layer at the top, and then knives down below, or a wine glass down below, and you reach down through the soap, and then that's how it happens. And I get those, I don't know, once a month, it seems like. So I'm always wearing my kids out about the injuries that I see, but I think they're sort of food for thought in life. Or rock climbing has a very specific injury, which is sort of interesting. There are these pulleys that are very strong, that the tendons go under, the flexor tendons, which are really strong. And if you grab on like that, the pulley literally right here can tear from a rock climbing injury. So when rock climbers come in with a finger injury that we're going straight after, did you tear your pulley? It's a little more unusual, and usually people don't get it from regular gripping stuff. It's that fingertip grip with that bowstringing that can tear through that pulley. So that's just a weird one. And then the one I want to end it on is Cinco de Mayo, because we just had this, and every Cinco de Mayo we have one or two of these. We get what's called avocado hand, and you can look it up yourself. It's a real thing. I love that this guy had it, have him take a picture here before taking the knife out. But this is the way not to do it, where your hand is under there. And it's a common way to do it. And if you're going to do it, go slow and think about it. And I also have our kids use a serrated blade. So a serrated blade, you have a lot more control over than a smooth one with that. And so it also doesn't tend to skive as easily off of that slippery, snotty thing. So that's the other way it happens, of course, is the most common is a blade comes through and then it hits that seed and bounces off, and the rest is history. And they can be a mess. I've operated on 8 or 10, at least, maybe more avocado hands. So let's not do that for Cinco de Mayo. So that is where we are. In summary, we're sort of always available for injuries. We all put into our schedule open slots for every clinic for an injury. So not necessarily for that chronic pain that's been going on for years, that may be arthritis, that, we try and accommodate that too. But if anybody calls with a frank injury, I worried I broke my what have you, or I just injured myself substantially with an acute injury, then we always are quick to add those on, because you're better off getting a diagnosis and going ahead and treating that. And if they need to be fixed, we like to fix everything injured sooner, because the anatomy is fresher, it's easier to put it back together, it's ready to be repaired, and so it's better for the patient and it's better for us to have an injury that's fresh. And then also one side thing, know that you can always request our group in any emergency room that you're at. So you can be in Summit County, you can be in the ER here, and if they say so-and-so's on call and they say, well, I've kind of used Vail Summit Orthopedics, and I've had good experience with them, can I request that group? And all the ER docs are very used to that, both directions, and they'll place a phone call to whoever's on the other end and see about how that works. And a lot of times it can work where it's like, great, yeah, let's get you admitted, and then someone from our practice especially will try and find the person that of course does a lot of that type of surgery to go do that. And so that's common, that you can request our group from the emergency room, and that's not a major, it doesn't put out the ER doc or the ER staff. It's literally one phone call, and most of the time we can make that work. Rarely, if it's a weird one and it's weird timing, then whoever does that may not be there. So there's a lot of scenarios, but if you trust us, then ask for us. So thank you for participating. Hopefully this will prevent some injuries maybe, which is one of the goals of these webinars. And we're here if anyone needs us.
All right, so we do have some questions. So this one is from Lloyd. He says, the pinky on my right hand is stiff and swollen. It can't bend down from the middle knuckle to the fingernail. I can't grip a golf club or a tennis racket completely. It is sensitive to try and bend and seems to be getting stiffer. Could this be arthritis?
So what I would first ask, of course, we'd take a quick x-ray and see if there's some arthritis, but more commonly there is something called a trigger finger. That's an inflammatory condition where the sort of whole finger hurts. It tends to be more pain towards the base. Let me put my hand in the right way, towards the base of the finger. So if you press here and it's like, that kind of hurts me, then that tends to be a trigger finger. And the trigger finger, patients complain of stiffness and pain in the morning often. And then it bends and it works, but the whole thing feels inflamed and stiff and painful. If patients say, nah, it's more one joint, it's more coming from one joint that feels stiff, that's more common, it's arthritis. But if it's, quote, the whole finger, and the whole thing feels stiff, then commonly it can be an inflammatory process in the tendon sheath that lives inside of here. And if that's the case, then again, if that's what we think it is, a quick injection carries at least a 90% success rate.
All right, and this question is from Caroline. I'm going to try and pronounce this correctly. Do you do surgery for Dupuytren's?
Yeah, Dupuytren's. So yeah, Dupuytren's contracture is back to the palm again, and patients will develop very slowly these cords and these nodules. They're quite firm, they're quite fibrous, and they tend to be on the little finger side, and they go down into the palm like this. They don't ever hurt. And so they're these like fibrous aberrant tissue that grows here. And then the telltale sign is people start to contract down, and you start to get more and more. It's much more common in men. And it contracts down like that, and then it gets in the way, and your hand is stuck like that. It can't open up. So then you can't get it into your pocket. You drop coins, things like that, and it's annoying. It doesn't hurt again, but it's annoying. And so the answer to that is yes, I do surgery to fix that by releasing that fibrous tissue, and then you release it and literally cut it out and throw it in the trash, and they do pretty well.
All right, this question is from William. I've heard deltoid muscle tears don't need surgery. Can you talk about treatment and time for recovery for that injury?
Yeah, so it's really an unusual injury. And so whenever I hear somebody has a deltoid muscle injury, I sometimes get second guess, like, all right, are we sure that's the right diagnosis? Because so many patients will have pain in their deltoid area where you feel on the outside here on your deltoid, but really it's your rotator cuff, which is hiding right underneath that. So that's the first thing, is to make sure it truly is a proven deltoid, because your deltoid brings your arm out, and so does your rotator cuff. And so if patients have pain when they touch on their deltoid, but they're bringing their arm out, it's like, yeah, it hurts. And they're doing this empty can business and the things I was talking about earlier, it's often not a deltoid injury. It's often a rotator cuff injury that's further under the deltoid. So that's probably one food for thought. And then if you do have a proven deltoid injury, those tend to heal great. And I would say proven would almost have to be an MRI to prove that it's your deltoid, not your rotator cuff. And so like anything in the human body, if it's a muscular tear and if it's a tear in muscle tissue, it's a real good healer. So you can take like the pectoralis muscle, you can take the gastrocsoleus, which is your calf muscle. Those pain, they hurt and they're real disabling, but they also don't need operations because they grow together predictably. So then you go further onto the tendon, like the Achilles tendon, there's a different deal with that. Take the pec muscle and it tears, that's fine, that heals. You go out to the pec tendon, that doesn't heal great. And it's very unusual to have a deltoid tendon attachment. And so it would be more muscular. And again, you want to make sure that that's the right diagnosis.
This question is from Meredith. I had a double torn meniscus, torn en route, and did PT to full function. 2 years later, I re-injured it, but did not do a repair since I was planning a full knee replacement. I could ski, but had severe pain on the chairlift and after skiing. I was told that a titanium knee brace would not help, but it seemed to help tremendously. Can you explain why I was without a lot of pain while skiing, but would be in a lot of pain afterwards?
Yeah, that's sort of interesting. Meaning that one of the hints she gave me was back to this cam thing. So when you're skiing, you're up like this, or maybe a little bit flexed, right? Well, that does not really load up the roots, the horns, which are way back in the back of the meniscus. So I'm going to try and show this somehow here. So let me see if I flip it this way. So the meniscus, way in the back here, and the way back is where the root where you had that repaired back in that area. And when you flex the knee down, it's going to load up that root because it's going to pinch that root back there. So all of a sudden you're on the ski lift. Well, yeah, you're flexed up, right? And you're kind of hanging on that in that flexed position. And so I bet that would tick it off. I bet that would, and I bet squatting makes it bad too, or a deep bend, because that would load up that root. And whether or not the root is tearing again, or whether or not that's where the arthritis is. That's where it kind of comes to where it's a little tricky to say, all right, is this the arthritis, or is it the root, or is it 50% arthritis pain? Because that's progressing, because you were told you may need a knee replacement, so you must have at least moderate, if not severe arthritis. So 50%, let's say, of your pain could be coming from arthritis, and 50% could be coming from the root tear. And then if you have that brace, then maybe it is unloading that root a little bit, or it could be unloading that the arthritis a little bit. And those could both help. But by all means, if it's letting you do what you want to do with a titanium brace, then do that. And then if it ever goes the other direction, then your backup plan is the knee replacement.
This question is from John. Can I get carpal tunnel from biking? After I started biking, my wrist would occasionally ache, and now it's a chronic pain to the point where it hurts to text on my phone.
So if carpal tunnel is the right diagnosis, then typically it's numbness and tingling. So carpal tunnel from biking is super common. And the reason it is because it lives literally right here. That's where carpal tunnel syndrome is in the wrist, is right in that crease. Well, that's exactly where, of course, the bar goes for that. And it's compressive. So I've gotten it before myself from a lot of mountain biking when I did a whole bunch more than I normally did. And then the vibration too. And then all of a sudden I started having numbness and tingling in these three fingers. So 1, 2, 3, these three fingers, thumb, and these two. That's where carpal tunnel is. And you see people biking and they shake it out. And they're like, God, I feel like I got to shake it out. I feel like blood supply. It's typically carpal tunnel, which is a nerve getting compressed there. And it's often worse at night. So, but you didn't mention nerve pain or numbness and tingling. You just said pain. And so if it's wrist pain, it could be something different. It could be like arthritis in the wrist or something like that. Sometimes we can see just inflamed tissue in the wrist. So it'd be important to find a distinction between is this wrist pain and swelling from the wrist, or is it numbness and tingling pain?
Okay, this question is from Maggie. Is tennis more dangerous than pickleball? I hear it's easier on the body, but I hear about more injuries from pickleball.
Yeah, that's curious, and I like to debate that too, because I see a lot of tennis injuries, but I also see a lot of pickleball injuries. And I guess I would liken it to there's a whole lot more quick pivot and shifting with pickleball by nature. So I liken it to a little bit more approaching badminton, where it's lots of little twists and lots of twists, back and forth, back and forth, back and forth, back and forth, back and forth. So the number of rotary torques in pickleball is a lot more common. And then the other thing that's probably true that I don't know that's ever been studied, but intuitively it seems true, is let's take a tennis player that has a little bit of arthritis. And they're like, well, I just can't run like I used to be able to with tennis, but I love racket sports, but I can't play tennis anymore. So now I'm playing pickleball. Well, they're going to have a little bit more of an arthritic knee. And if that's why they quit tennis, because of their knee. And so you extrapolate forward. So then you got a little arthritis. Well, then that's banging up your meniscus. And then you twist again with the common twist. And then there you go. You tear your meniscus from pickleball. So I don't know statistically if like you took 10,000 tennis players and 10,000 pickleball players, if there's more injuries from pickleball, intuitively it seems like there would be from the knee specifically, because it's true. I don't get that many knee injuries from tennis. There's some, but it's usually a fall where they fall down or trip or have a big twist. So there's real different physics. So I think I would have to vote statistically for pickleball having a little higher, at least meniscal injuries than tennis.
Okay, this is the final question. I've been having knee pain while golfing. What types of knee injuries are common in golfers?
Yeah, another good question. So golfing, of course, doesn't have that pounding like hiking downhill. It's got that rotary torque, but it's a little bit of a more controlled rotary torque. It's not the super quick pivot, quick pivot back and forth. And so, especially with a big drive, let's call it, there's that kind of quick rotary torque that happens every now and then in golf. And if patients are having knee pain from golfing, the first two things that we think of are the most common things, of course, which is there a little bit of arthritis? Is there a piece of cartilage that's loose and they're flopping around, bugging you, getting pinched? or is it just inflamed from some arthritis and you're impinging the soft tissue? That's a good scenario where your knee's mad, inflamed, irritated, and the synovium is red and angry, and then those respond beautifully to a steroid injection that'll reset the button. Or versus, well, I had one swing, and ever since that swing, I've had knee pain. That's the type that we're more worried of a single cartilage injury or meniscus tear.
Okay.
And then that's kind of about it for that. There's some more rare tendonitis, bursitis that we'll see from golf, but I think it'd be more common the first two things.
Those are all the questions we have.
All right. Well, thanks for joining, and hopefully everybody got at least something out of there, and cutting an avocado might be the only thing.
Make sure your contact information will come on the next slide.
So thanks again, everybody.